Hello, everyone. Welcome to our 35th episode where we will be talking about plantar fasciitis. Dr. Sandoval has provided a step-by-step guide for us on how to treat and rehabilitate this injury. So we're excited to talk about it. Before we get going, I just want to say that our blog, all of our blog discussions and all of our podcast episodes, all 35 of them, are up for your listening and watching pleasure. Anywhere you watch your podcasts, anywhere you want to see them, Apple, Amazon, Spotify, any place that you actually tune in, go watch those, go binge listen to those. Also, they're up for your viewing pleasure on YouTube under our blogcast,
Blogcast.
podcast.
We can start a new term.
Yeah.
Blogcast.
I think
It
it's a
sounds
good-
cool.
Our blogs have been podcasts, so
I think we can mesh it.
you're on to something.
Yeah. So, anyways, on YouTube, you can go watch those and binge watch them. Go watch all of the 35 episodes. And going forward, we will be releasing them monthly. So mid-month, you will get a brand new episode, which will start next month. So we are in our ankle series this period of time. And so Dr. Sandoval chose to write on plantar fasciitis. And so, Dr. Sandoval, why don't you start us off and let us know why you chose to pick this topic?
I'm going to be honest. I don't remember. I think I was just inspired that day. I said, you know what? Let's talk about the foot and ankle. Let me talk about plantar fasciitis. That seems very interesting. Let's talk about it.
All
I
right.
think we were thinking that it maybe impacts a lot of people.
Oh, yes,
that's
that
what
is
the
very true. It's
That's
applicable
why
to
it would
all
be
of you.
important to
Yes.
teach everyone about it.
Well, and you had it too.
Yeah.
No, I didn't.
You didn't?
No, you had
When
it.
you were oh yeah, I had it, but
Yeah.
yeah.
No, I
Okay.
didn't have it.
Oh.
I think that
My bad.
everybody picked a topic and then you got stuck with it.
Yeah, I was trying
Probably.
not to say that.
Yeah,
That
Whatever.
probably was what happened. Yeah.
Yeah.
So, anyways, okay. So you wrote this wonderful, amazing step-by-step rehab procedure for us on plantar fasciitis. So we're going to talk about this. So Dr. Bay is going to lead us in, and she's going to talk to us about anatomy and some symptoms that you might experience if you have this condition.
All right, thank you so much for that intro, Dr. Brown.
Yeah, you're welcome.
So, I'm going to talk to you a little bit about the structure of the plantar fascia today. So, if this is our foot, the bottom portion, or also known as the plantar surface of the foot, is where we find our plantar fascia. This is a thick band of fibrous tissue, and it starts at the base of the heel and it spans up towards our toes. And this tissue is very important in maintaining the arch of our foot while we're standing or weight bearing any type of activity that's loading. Okay. So we injure the plantar fascia when we're exposing our body to increased loads, higher stress, higher volumes. And there's a couple factors that are going to contribute to us having this injury. So the first would be that we have increased the volume of our high impact activities or that we do them very often. The next is that our foot posture is not the typical average normal foot posture. You might find that people with flatter than normal arches or in the opposite, higher than normal arches would be prone to having plantar fasciitis. Also, based on the needs of your foot, if you don't have the proper footwear to suit your particular foot's needs, that could change the way your foot is working and overstress this. Changes in your body composition. And lastly, calf muscles that are too tight. People that have plantar fasciitis, the symptoms they report are typically a sharp or stabbing pain right down at the heel. The most common thing we hear is that this pain is like the first couple steps in the morning. It's hard to even put weight on your foot. It's very intense. Also similar to getting up for the first time in the day is should you have sat too long or stood too long and you haven't moved much, trying to transition to get moving again is pretty painful. And then lastly is that typically when you're loading, doing weight-bearing activities on harder surfaces, that would also potentially be very aggravating to our plantar fascia. And
Yeah.
there it is.
Wonderful. I think we should clap for her
I made it.
or snap for her or do
I
something
made it.
special.
I survived.
I made it through. Okay, well so in plantar fasciitis in general, like I feel like I think you might have said this in the beginning of it too, is it's a very like nagging, like annoying sort of thing, right? So Dr. D just shared with us that he has had it before. So do you recall like some of your specific symptoms? Like did you have all those symptoms or do you remember clearly like what set it apart from maybe something else?
I think for me, it was more so. I don't remember exactly how it started, but I think it was for when I was preparing for a running event. Yeah,
Okay.
I was doing the Ragnar relay and I was starting to run, and I think I progressed the distance too quickly, and it was probably
Mm.
footwear as well because my shoes are pretty old at that point, and I didn't want to buy new shoes for something where because it's a trail relay, so it's gonna get ruined anyways. I didn't want to buy new shoes for this, so that was probably one of the reasons why I started to have it. But during my training, I started to rehab it myself and started to grade the distance a little bit more, change the inclination, decline, things like that, the terrain, and it started to get better. So
Yeah.
it took some time though. I think it took like a month or a month and a half or so to go away, but
Wow.
I think the key was to not stop training. I just had to modify it a little bit to start off.
Yeah.
Yeah.
We do see it a lot in our runners. Do you remember like um early on or when you were preparing for this particular you said you were running more.
Mhm.
So we're doing a little morning. Do you remember like incorporating more prep work towards your foot and ankle or did you kind of just go about your normal like routine of how you were strength training and doing things or did strength training reduce at all during that time?
I was doing a lot more isometric work prior to my runs.
Okay.
Just because typically I would be running first thing in the morning, so
Mhm.
I did a lot more warm ups prior to the run itself, and the places I was running at they would have a lot more stoplights. So
Mhm.
during all those stops, I would do certain exercises in between too to kind of modify certain things
Mhm.
or modulate it. And it felt a lot better during the run. So,
Yeah.
because sometimes the symptoms will slowly start to come on, and during those periods, I would be able to turn it off and then
Mm.
start to run again. So,
Yeah.
yeah.
Because I guess my question was like, do you feel like you still did all the right things in your training um, to like maybe potentially prevent something like that from happening? And it came on because slow or solely because of the load, like the increased load. You know what I mean?
I think at that point, I wasn't really doing that many plyometrics on my own.
Okay.
Now I do it all the time, so
Yeah.
I don't really have any foot problems
Yeah.
anymore. But that was probably the one thing that I was lacking in my training because I was
Okay.
still lifting, obviously running. I think I was sprinting, probably not as much, but the plyo work was very minimal.
Okay.
Yeah.
Yeah. Has anybody else had any like patients in the recent, I don't know, could be 6 months, a year, whatever, but that you remember like their direct complaints of symptom, like what their direct complaints of symptoms were. Cause for me, the last patient I had, it was like just a aching, burning morning, waking up in the morning, just irritable. Their feet feel like they're on fire when they got up in the morning and they just were like, it's almost like walking on hot coals. Let's just get moving, you know? That was what I remember. I've remembered the last patient telling me.
Yeah,
Yeah.
very much like that.
Yeah.
That's very typical.
Yeah.
Mhm.
Yeah. You guys too. Cool.
Mhm.
Okay. Well, that is our anatomy and that is our symptom. Our symptoms. We're going to go into the rehabilitative process. So we'll have Dr. Sandoval open with us about what the rehabilitative process looks like and a little bit of intro into there. And then he's going to take us through phase one.
Yeah, so I wanted to keep this short and sweet. There are basically three simple phases that you follow. There's the first phase where you just want to manage the symptoms, right, and
Mhm.
try to modulate them and reduce them. And then you move into building more capacity through
Mhm.
strength training and flexibility. And then you want to, gradually return back to the activities that you like, sports, and then, move toward prevention, right? I think it's important to note that not all of these phases are, strictly in and of themselves like their own phases. They kind of blend in together, right? So yeah, those are the three main phases. So if we were to dive deeper into the first phase, right, pain management, one thing that I want to highlight is something that Dr. D said, which is, you know, he didn't stop running, right? And you don't want to stop the activities that you enjoy doing. You want to modify these activities and make sure that you're doing them in a way that doesn't exacerbate your symptoms and doesn't make things worse. We want to make things sustainable over a long period of time. So in this particular instance, you want to do something that's called active rest, right? So you don't want to stop doing these things. You want to just modulate them and deload everything, but still do things. Does that make sense?
Yep. It makes lots of sense. Yeah.
Some other things that we could do during this phase are stretches. We can do some more, some soft tissue techniques to kind of, further deload the other structures in and around the plantar fascia, right? And then some other things that we could incorporate in this phase are potentially our orthotics or taping techniques to just further deload those structures.
Cool. I remember the last patient I had, or just I guess patients in general, plantar fasciitis in general. I've spent more time probably doing some manuals on them, some soft tissue work. I have had patients that have had it really bad, where like it's almost like nodules that they have along the tissue, right? The tissue thickens so much that you're just, and there's some that like I couldn't get rid of those, even though we progressed the actual condition and got rid of the foot pain and stuff. But it does change, I think the inflammation in the tissue does change the tissue quality, overall, if you probably try to live with it. Or this is one of those conditions where people like, they get it, they stop doing some things, and then they don't really ever rehab it. And then they go back to them, and then it's kind of like a flip-floppy condition. I don't know if you guys have experienced that as well, but a lot of patients, try to self-manage it. And so it can be like a patellar tendonitis, where it's like a long form irritable thing that people just kind of go back and forth from. So I think we do spend a little more time on that. I've noticed that taping has helped, like KT taping has been beneficial for patients that I've had in the early stages to just deload. It's a good technique to just make them feel like their tissue's being hugged a little bit in the rehab process, early stages. And I just think activating that arch a little bit, like in a different way than it's being activated when they're on their feet all the time. Yeah. Do you guys have any early stage things that you really have tapped into or like using with patients that you've had before with plantar fasciitis? Dibe likes the foot.
I was just waiting for you to say this.
She takes all of our foot patients. That's why she wanted to do the anatomy, because she wanted to let you guys know that she does know where the lateral ankle is, and she does know where the medial ankle is.
Yeah, I like the feet. I also like the whole lower body, just to be clear.
She likes it all.
Okay, so
I just like to mess with her.
One of the points that was brought up when I was discussing the variables that make this more likely to happen to you is the foot postures, overly pronated or flat, excessively supinated or high arched. In my style of treatment, I would probably do a lot of joint mobilizations or using tools like the blackboards or the wobble board to try to improve someone's rear foot mobility to help their arch kind of normalize towards mechanics that would be a little bit more functional to not overload the plantar fascia.
Thank you for bringing that up. I would probably spend a lot of time on the subtalar joint too.
Yeah.
It's
all about that subtalar.
Yeah. I mean, the thing is, like, you're fighting sometimes people's anatomy. Like
Yeah.
if they're a natural supinator and, you're going to maybe not make great changes, but you're going to give them more mobility and teach them to go the other way a little better.
Yeah, definitely.
Yeah.
Then the other thing is just, as with a lot of injuries we see, if people lack proximal stability, that might be a reason they're overusing some of their distal joints. So in this early phase, I would probably do a lot of hip and core strengthening.
Yeah.
Try to even them out, equalize who's coming to the party to help.
Yeah. You love the core too.
Always.
Guys, anything to add?
Probably along the same lines that I think most of the time people will orient their foot so their forefoot and that rear foot are both going in one direction versus going in the opposite. It should be having relative motion, one moving in the other direction, one moving the opposite direction. So the blackboard comes in handy with that aspect of it, and getting that person to understand what true pronation actually is, true supination actually is makes a pretty big difference.
Yeah. Dr. Sandoval, anything?
Nothing.
I concur.
Okay. Hey, we said blackboard at least 10 times. I feel like we need to get some sort of blackboard like sponsorship. Blackboard.
Blackboard.
We like you.
Well, I already got a free blackboard, but I would love some of those toe strength bands.
Oh
Mm.
yeah.
Do you hear that, Blackboard?
Blackboard.
We'll be tagging you.
Is it Blackboard or international? They're from a different country, right?
I want to
I
say
don't
it's
know.
in the
Oh, yeah, they
southern
are. Mhm.
hemisphere.
Right?
Yeah,
Yeah.
They
That's what I
are.
thought.
They're somewhere else. Okay, I'm going to go over phase 2, which is flexibility and strength training. And so some of the things that we do in this phase are gait analysis. So looking at how you walk. Do you go through all the phases of the gait cycle? Probably how you run. If this is a running injury, I'm going to put you on the treadmill and I'm going to put you on in slow-mo and take a look at you from the side and the front and the back and just see kind of how your running mechanics are. Stretching. So are you flexible? Do you have flexibility in that plantar fascia? Is your Achilles tendon tight? Is your calf tight? Is your soleus gastroc? Which part of that might be tight? Do you have good mobility? Your ankle mobility. We're checking those things in the initial phases too, but we're going to continue going after some just mobility and flexibility all around your lower body flexibility, how your hamstrings, how your quads, all those things as well. Continuing that, probably initiating in phase 1 and continuing to phase 2. We are going to do some eccentrics in the stage. So going after how you're moving eccentrically with strength work and just general foot strength altogether. So, how are your intrinsics moving in your foot? How is your calf strength? How is your, all your movements, eversion, inversion, all the movements of the ankle, dorsiflexion. We're going to go after sort of all your foot strength during this phase and probably get you working hard. We're going to go after your lower extremity strength. So, how a lot of times with these things, like we find, okay, the foot is problematic, right? The foot is irritated for some reason, but like maybe there are other co-contributors to why the foot are maybe working so hard. So what's going on in other areas of your body? Are your hips strong? Are your glutes strong? Is your glute med strong? We're just going to look for all these, any deficiencies we see and put that in this area of the programming to make sure we're focusing on that. And then we definitely go after balance and proprioception in this stage too. So, how is your balance? It's funny. A lot of people, you get them on just to stand on one leg and they cannot stand on one leg for like 5 or 10 seconds. And this is a lot of people that don't even have strength deficits, right? So balance is important. We have to balance in real life. We have to be able to move. Earlier, I was going down to pick up something off the ground and I had one leg in the air and the other leg was down. If I didn't have good balance, I could have probably tipped over. So it's important that in our functional movements that we can balance, right? Not just with what Dr. Bay's patients do, which is balancing on their tippy toes, but like balancing just on your foot, right? So we're going to go after that. And we're going to have you probably do things like, dynamic things like tossing a ball, maybe taking, going on the BOSU and balancing. We might have you on the wobble board. We could do all kinds of fun balance things in this area. And I think that's it. Did I miss anything of phase 2 that you guys do?
No, I don't think so.
Well, that was very thorough.
I thought so.
Yeah.
I'm pretty thorough.
Sounded like hard work.
It's a lot of hard work.
Which is why, people don't want to do the hard work sometimes, It's hard to do hard work.
I would assume so.
That's why they usually come in chronic because they've been avoiding
Yeah.
the
Yeah,
hard
that's
work
true,
as
that's
long
true.
as possible.
Yeah.
Yeah, my bet is that this is a phase that most people don't actually, push through to make sure that they don't end up in the situation again.
Yeah. This is one of those conditions where people like phase 1 and then they're out.
Yeah.
Oftentimes, right? Because they're like,
Feeling
oh,
better.
Or
my
in
foot
and out.
feels better and I can go. But really, this is probably the most important phase of all of them. Unless you play sports, if you play sports, then we want you to get to that phase, that third phase, which Dr. D is going to take us through. So why don't you tell us a little about phase 3?
So this is kind of the fun part, right? For most people, it's going to be a return to activity or sport that you have in mind. And you don't necessarily have to be in a sport to be in this phase either, right? It could just be a casual walker too. So it'll be more so getting yourself exposed to certain distances, certain terrains, kind of like what we were talking about a little bit earlier. So that will be their sport of being able to walk ideally indefinitely as much as possible, just making sure that we are gradually increasing the demand at hand so that our body can keep up with it. So, but the programming itself, from the beginning, it should be individualized, but this is probably the area where it gets more individualized for that person, depending on the sport or whatever demand at hand. So we'll go into plyometrics, we'll run, we'll sprint, we'll change directions, whatever you need for the sport or the activity that we're trying to get back to doing, and gradually increasing the demand of those things. So we need that plantar fascia to be able to stretch, shorten as rapidly as possible without changing mechanics as well. And this is probably the area where we start testing too, right? I mean, we're typically testing from the beginning, but we start to go into our single leg hop tests, our triple hops, our lateral hops, our 6-meter hops, whatever we need to get as much information as possible so that we know this person's ready for the sport itself. And also just doing sport specific stuff. If that person plays, I don't know, lacrosse or something, right? So the mechanics of running is going to be a little bit different than, say, soccer players, where they can actually use their arms as much as possible. But for lacrosse, they're going to be holding a stick. So that changes the demand as well. So we want to get them as prepared as possible for the sport without playing the actual sport. So that we can build up their confidence, and then they'll return to sport first before returning to play. They get exposed to the field or the pitch or whatever people call it at this point. But pitch is European, right?
Yeah.
Yeah.
You're hearing pitch a lot right now because we're in the World Cup.
I don't know what
times.
pitch is.
The pitch is the field.
No need.
It's okay. It's not the dance floor.
Nope.
It is.
Not pitching baseball either. So.
I figured that
Yeah.
out.
But yeah, so then they get back into the sport. They're getting back into their team, their regular routine. We're still checking in with them at this point as well, right? They're coming in. It's like, okay, I was able to practice for this week. And then what can I do now? What can I add more to my practice now? And then obviously we're trying to communicate that with the coach as well as much as possible. And then just getting back into play.
Yeah.
Yep.
So when we talk about plantar fasciitis rehab, is there anything particular that is like and that was wonderful, Dr. D. Thank you. You deserve some snaps too. Yeah.
Okay.
Yeah. Is there anything that you guys feel like is kind of like I must like check this, or this is something that they must have to like pass? I know you might have some tests. Dr. Bay has some tests that you have to pass, foot tests, but that I probably can't pass either. So don't feel bad. But like, is there any like tests that you guys, or things that you think you would make sure with this particular condition that is done any different than any other maybe foot or ankle injury that you think is important, that maybe these, in either phase? Probably I'm talking about like phase 2, phase 3.
Calf raises?
Calf raises?
Yeah.
Do you want to be specific for us?
I'm still laughing.
I mean, they should be able to do 25 calf raises on
For a
both sides.
walker.
Yeah, for just a normal person. So
Well, we're really into soleus strength right now.
yeah.
Right.
Yeah,
So
I
we'll
see
do
that.
Because
straight
it's very
leg.
much shock absorbing,
Right.
which is very important for plantar fascia concerns.
So what are your recommendations?
Well, I would say clinical pearl wise for plantar fasciitis, sometimes it's not the most straightforward condition, and there can be multiple variables besides the plantar fasciitis. So making sure that you have proper flexibility of your big toe, and like the tendon that runs underneath the flexor hallucis longus. Sometimes when that's shortened, it contributes. And I always think neural tension plays a role in some of these syndromes. But I mean, everything he said.
What about like how many hill raises you should have to do?
Well, it's my understanding, but I am not up to date on the latest research. I let them update me.
There are like
often.
Yeah, there are
But-
different numbers for like different age groups
So,
and different sports.
My
right?
understanding is that if you're going to be in a sport that requires running and jumping, it should be more like 35.
Single
Is
leg.
it single
Mhm.
leg? Is that different now? Or is that still
I have
the
no idea.
standard?
Are you caught up?
25 is general rule of thumb for most people.
Average
If you're gonna be,
population.
yeah, if you're a younger individual, like younger than 30 years old, and you play a sport, you want to be closer to 30, 35
Oh,
at
Mhm.
Good
least.
to know.
Yeah. So that's the standards I
So
did.
can you do
So I'm trying to
25?
clear my dancer right now, right? For her calf raises to return to point. She was able to do 30. So I go, okay, that's enough calf strength for me.
Question is, can you do 25 to 35 single leg hill raises?
Mhm.
Bent and straight knee.
Bent knee and straight knee.
I think so, yeah.
Yeah,
Bent knee and
that's
straight
how
knee.
I've been testing it.
Yeah.
Okay, good. Those are good. Those are good things. Okay. And why do you think that is important for plantar fasciitis?
Why do I think?
You.
Well, I know
Yep. You tell me.
that we cannot eccentrically control dorsiflexion when we're loading if we don't have enough calf strength.
There it is.
That's what I know.
And produce force, right?
Yeah.
To come out of that position.
Okay.
What do you know about that?
Do we not know something?
No, no.
There's some
So
secret that we don't know.
suggestive.
Well, no, like what's in your brain, they don't know. So I'm just trying to pull that brain knowledge out for all of our listeners. 'Cause
Great.
You know things that they don't know.
I know some
Okay.
people test using a what is it, a handheld dynamometer or like a
Mhm.
smaller variation of one for the man. I always say this wrong. What's the big toe one? Flexor hallucis longus
Yeah.
Mhm.
strength.
Yeah.
I know some people test that too.
Oh, what are
just to
the
get
parameters
Ab-
for that?
Absolutely no idea.
I don't know. that one.
Symmetrical.
I have no idea.
Hmm.
But I'm sure there's some type of research done on it. Is
Maybe.
my guess.
What about plyometrics or anything jump wise that are like that you would want to be like with this particular type of patient? Maybe that does a team sport or a sport that involves jumping, hopping, transitions that you guys would like keep as an objective test for them, or that you'd want to make sure incorporate for the like I'm saying like plantar fasciitis versus maybe like an ankle sprain or something like. Is there anything different you would do?
Yeah,
Or you want-
I mean, I would take a look at the tests that he was mentioning earlier, like the single hop, the triple hop,
Okay.
lateral hop tests, just to make sure that they're even and symmetrical on both sides,
Okay.
and that there's no pain or any weird movements that we see.
Okay.
That's it.
In the dance world, I'm kind of looking more at the height and if they can point their toes clear enough to point their toes, and like probably watching slow mo, can they push with their toes?
Mm-hmm.
I always like really nice landings.
Yeah.
Oh, nice soft landings.
And I think for vertical hops, you can't really mask the strategy as well. It's either you have it or you don't. Horizontal
exactly.
propulsion, it's a little bit, people have knee strategies, hip strategies, and could look very different. But I mean, if you're going up, you got to go up. There's really no way out of it. So yeah.
We talked about runners being somebody who are at risk for this, and we see a lot sport-wise runners. Is there anybody else that you guys have seen that often get this particular condition, patient-wise? I would say for general population, it's just people on their feet all day. So people who are standing all day. So I've had some longshoremen with this because they're just on their feet all day. Also like the UTR drivers who are like constantly doing like this motion.
Oh.
So anything like that. But what about sport wise? Is there any other sports that we see this commonly come from?
I don't know why I want to say hockey or figure skating, because I feel like they get weak ankles from being always in their skate.
Mm-hmm. Instability. Yeah.
But I could be
can see
making
that.
that up, but I feel like I have noticed that trend.
Most of the people I've seen honestly are runners. So this
Yeah,
is
I think
so
it's
if
a
you're a
running
runner,
thing.
this is something that I definitely think is a condition you have to look out for and be. And I think the best way to prevent this is to strength train, which and focus on stability and strength your ankles. And that's a lot of times the missing piece with a lot of the patients that come to me that are runners is they don't strength train. And a lot of them do stretch, but they don't do like dynamic like movements, right? So
Yeah.
yeah.
We can't just be foam rolling all the time. We
Yeah.
actually need to
What?
strength train.
Foam rolling.
And also, right, the whole package, the proper warm ups,
Yeah.
right?
It's all a package, yeah, for sure. Yeah, it is for sure. Okay, well, we have covered plantar fasciitis unless there's something that you guys want to say. That okay.
Mm-mm.
No, I think
I'm
we
good.
covered it. I think this
Very good.
step-by-step rehab plan that you gave us was very effective.
You're welcome.
Dr. Sandoval, appreciate you. All right, guys. So that is the end of our discussion. I want to remind you, go binge watch our episodes on YouTube and where you watch your podcasts. Please rate, review, chime in. We want you to be a part of this discussion. We want to know what you have to say. So do that for us. And also let us know if there's topics that you want for us to discuss. We can discuss. We have kind of a plan for the ankle, but we can always change our plan. So let us know if there's anything particular you guys want us to discuss as we move forward in our series. You can check us out on Instagram at Physical Therapy San Pedro, Facebook as well. And you can check out our website. And if you have a foot injury and you need some help,
Dr. Bay.
Dr. Bay's dying to help you, and she can
I'd
help
love to
you
help.
in the clinic, and
But
she can
again,
help you.
I'm not obsessed with
And she can help you virtually. So if you aren't in this area,
They're really good virtually.
yeah,
though.
actually, Dr. D loves telehealth.
Oh.
So if you want to, if you need some help, we can help you all over the world. Check us out. Send us a message. We'll see you guys next time. Bye.